Blood flow and the oxygen content of blood determine oxygen delivery to the tissues. Flow itself is determined by the force of the heart and the resistance of the vascular beds it supplies. Flow measurements can also tell us about the importance of shunts resulting from abnormal connections between the systemic and pulmonary circulations, and measurement of forward and backwards flow is a way to assess the severity of valvular regurgitation. Finally, the reduction in flow can help determine the significance of any anatomical obstruction in the cardiovascular system. So how can we measure flow? Well, the conventional gold standard is the FIC technique, which requires measurement of the difference between the oxygen concentration in inspired and expired gas to measure oxygen consumption and compare that with the difference in the arterial and venous saturations of systemic and pulmonary vascular beds. The disadvantage of that, of course, is that it's very invasive. And the non-invasive techniques that are commonly used are Doppler and Cine phase contrast MRI. And Doppler is quite inaccurate, partly because it can be difficult to get an adequate angle of insonation, but also hard to measure the vessel area properly. And it's almost impossible to account for the different velocities that are occurring across the lumen of the vessel. By contrast with MRI, you can orient the imaging plane in any orientation, and you're simultaneously measuring the flow in each of the voxels across the vessel lumen in order to get a much more accurate measurement of blood flow. So how does it work? Well, phase contrast imaging takes advantage of the phase shift of the spins, which occurs when they move along a magnetic field gradient. So in this diagram, we see the subject lying in the magnet in a uniform magnetic field, with the spins all in the same direction. If a gradient is applied by making the field stronger at the patient's head than at their feet, a phase shift occurs as the precessional frequency increases in proportion to the field strength. So here's the gradient being applied, and the phase shift being shown here by the clockwise rotation of the arrows. If the gradient's then reversed for the same duration, the spins will be realigned, resulting in no phase shift, no net phase shift. However, if we consider what would happen to the spins in blood moving through the field and in the direction of the gradient, we'll see that the first gradient applied will affect these spins in the same way. But by the time the reverse gradient is applied, the spins have moved along the vessel, and now the new spins that are coming into the slice won't have experienced the initial gradient, and these spins that have moved along will be experiencing a different reverse gradient. And so that results in a net change in phase of those spins in the vessel, and which is actually proportional to the velocity of the blood flow. So how do we actually make a measurement? Well, the first step is to find the vessel that we're interested in, and anatomical sequences like the ones we've just heard about are used to define the vessel orientation. To make a phase contrast Cine flow measurement, it's important to orient your slice perpendicular to the vessel of interest. This is achieved by acquiring two orthogonal views of the vessel and then aligning the imaging plane at right angles to the vessel. I made these figures to illustrate slice positions for fetal vessels, but they apply equally well for postnatal patients. Performing a phase contrast assessment in each of the major vessels provides a complete picture of the distribution of blood flow in the circulation, and the small extra time investment can be invaluable in cases where the hemodynamics are complicated. So the next consideration is really about spatial and temporal resolution. We recommend free breathing, making phase contrast with free breathing with 3 signal averages, which eliminates the effect of respiration on flow, and it's easy for children to cooperate with, although you can make accurate phase contrast measurements with a single breath hold. So temporal and spatial resolution need to be adjusted according to the vessel size and the heart rate. So a good rule of thumb is that you should have a minimum of 3 voxels across the diameter of the vessel, but ideally much more than that. We all aim to achieve 25 true cardiac phases, and this makes it necessary to adjust your number of views per segment according to the heart rate. Adequate resolution ensures that you accurately capture the flow pattern and also the flow volume. Finally, the other setting that needs to be changed is the velocity encoding velocity, which ideally you set just above the highest velocity that you are likely to get in that vessel. So this is what they look like. You get a pair of images. On the left is the actual phase information, and on the right is the so-called modulus image, which is a good roadmap for helping you draw the contours that you're going to make to actually add up the flow in each of those vessels. And this is done with semi-automated tools, which will give you the flows that can be expressed either in mils per beat or in mils per minute, or liters per minute, and these should be indexed to the body surface area. How accurate is phase contrast? Well, in flow phantoms, we know it's very accurate, but it also seems to be accurate in patients. Here are two studies that compared phase contrast with FIC for measuring blood flow, in this study for measuring pulmonary vascular resistance, and in this one for measuring left to right shunt, showing excellent correlation with the FIC technique. But it's important to recognize your limitations, and we know that the accuracy of phase contrast diminishes when there's turbulent flow. And that's where it's important to use those other flow measurements that you made in the rest of the circulation in order to help you use an internal validation to recognize which measurements you've made are inaccurate. So a very common indication for phase contrast is the quantification of pulmonary regurgitation after repair of tetralogy. These are typical flow waves that you get in the main pulmonary artery, the right and left pulmonary arteries, here with a very symmetric pattern. And the sum of the pulmonary regurgitation from the right and left pulmonary arteries correlates with the pulmonary regurgitation in the main pulmonary artery. So I think I've run out of time. I had some other examples, but I'm sure we're going to be covering those in the rest of the other sessions.